today we will briefly talk about different types of anxiety disorders, their demographic characteristics, clinical presentation, what's the DSM-5 criteria, medications. One thing that I want to lay out there is from DSM-4 to DSM-5, there has been shift. In DSM-5, panic disorder, agoraphobia, phobias in general, generalized anxiety disorder, separation anxiety disorder, and social anxiety disorder are clustered under anxiety disorder. Obsessive compulsive disorder and post-traumatic stress disorder are no more under the heading of anxiety disorder. Post-traumatic stress disorder is under trauma and stress-related disorder. Obsessive compulsive disorder also has gone under another cluster. But I think, some of these questions will come and we'll be happy to cater those questions. Anxiety is an anticipation of a future concern, and it is associated with physical symptoms and also behavioral symptoms. On the other hand, fear is an emotional response to an immediate threat, and it is associated with our fight or flight reaction, which is more associated with autonomic nervous system. So you see some part of the fear is normally tuned in our body, or is part of our reflexes. But anxiety is something a little bit more. And when it becomes pathological, that's when it becomes concerned. I tried to look for Pakistan-based data for anxiety disorders. I couldn't come across any authentic studies, but just to look at these numbers, and this gives you some idea. I don't want you to remember the numbers, but specific phobias, they are 8 to 12%. Social anxiety is 7%. Panic disorders are 2 to 3%. Agoraphobia is 1 to 3%. Generalized anxiety disorder is 2%. And then separation anxiety disorder. So specific phobias are among the most common anxiety disorders. So for example, growing up in Pakistan, I'm scared of dogs and sort of run away from dogs. So that's my phobia towards dogs. And then see out of 100, how many have anxiety disorders. So it is not an uncommon illness. So some of the symptoms, like I previously mentioned, of anxiety can reflect in physiological symptoms like palpitation, chest pain, shortness of breath, feeling of closing in, headaches, muscle tension, and those sorts of things. And then second thing is when you're aware of the being nervous and being frightened, that can also cause increased anxiety and irritability. And we see that, for example, feeling ashamed in separation anxiety disorder. It can happen in others too. Cognitive effects of anxiety can occur, such as it can cause confusion, distortion of perception. It can also affect concentration because you have so many racing thoughts going through your mind that you cannot really focus, and you cannot associate things and make connections among different aspects of a single domain of your life. What happens is, because of your anxiety, because of your cognitive distortions, your mind is trained to focus on one thing and then find evidence from your past experience to justify those fears. And that's how these anxieties are augmented. So they go in a circle and kind of feeds in until you break that circle. Regarding epidemiology of anxiety, so about 1 in 4th, so every 4th person has an anxiety disorders. So see, it's roughly about 25%, which is a really significant number. Women are more commonly have anxiety disorders, and prevalence of anxiety disorders can decrease with socioeconomic status. So, social adversities can also play a role. So it's one of the most common disorders that you would see in your practice. And it's not that, patients who are coming to primary care clinic, they will only come with physiological illnesses that can also have comorbid issues such as anxiety disorders. So we need to check for them. Some of the systems that are involved are serotonin, GABA, norepinephrine. Limbic system is part of the brain which is involved in generation of fear and anxiety responses. And it also stores emotional memory. So for example, in PTSD, because of that emotional memory, a limbic system can be hyperactive, and that's how it generates increased anxiety. Frontal cortex and temporal cortex is also involved in anxiety disorders. So I will go over briefly panic disorders, then agoraphobia and generalized anxiety disorder. Then we'll talk about treatment. Most common comorbidity with panic disorders is agoraphobia. Agoraphobia is fear of going to the places because of some shame that is associated with it. Panic disorder can increase the risk of suicide. So lifetime prevalence is 1 to 4%, more common in women. Mean age of presentation is 25 years. So if I give you sort of life course of onset of these anxiety disorders. So first one that appears is separation anxiety disorder. Little kids can also have anxiety disorders, but their symptoms are more non-specific, and you cannot really categorize them into any anxiety disorder. The next one would be separation anxiety disorder, then social anxiety and generalized anxiety disorder. And panic disorder is generally is one that has later age of onset. In other literature I have read about that was relevant to adolescent population, it is usually around 16 to 18 when we see an onset of panic disorder. And the significance of remembering these ages, or when you are seeing these patients in your primary care setting, you can, from the onset, you can see whether it can be panic disorder or it can be another reason for underlying anxiety. First degree relatives of patients have higher risk of panic disorders, so there is a genetic element. In the comorbidity, forget about these numbers. So 91% have another psychiatric disorder. So if a patient comes to you for panic disorder, always look for whether something else is there. 1/3 of patients who actually have panic disorder, they have major depressive disorder. And for any other anxiety disorders, depression is highly comorbid. And then there are some other numbers that you need to remember. So it can happen with other anxiety disorders too. So what is a panic attack? So panic attack is sort of like a chest pain, right? When you have a chest pain can happen because of so many different reasons, right? It can be musculoskeletal, it can be because of myocardial infarction, it can be because of another reason. So panic attack is not a diagnosis per se, it is a symptom like chest pain. So when a patient comes to you with chest pain or panic attack, you need to see what is exactly causing this panic attack. Some people, because of their generalized anxiety disorder, they can have panic attacks. People with PTSD, when they have exposure to their trauma stimuli, they can have panic attacks. So you need to see what constitutes panic attacks. So it's a sudden period of intense fear or apprehension that may last for a few minutes to an hour. And it generally lasts for 20 to 30 minutes. So if it is lasting for a whole day, then it needs to think about something else. So panic attacks, like I was mentioning, it can happen in other conditions too. And if, they're lasting for a significant length of time, if there is an associated trigger, always look for other illnesses. And it can be expected, unexpected, or it can be driven by the situation. What's the DSM-5 criteria? It's a recurrent. So recurrent is the word that you need to remember, right? It's not one panic attack that would constitute panic disorder. Recurrent panic attacks, which are unexpected, right? And there's an abrupt surge of intense fear that reaches to peak within a minute during which time 4 symptoms are present. And just, get an idea of what that means. You can also look for a mnemonic, student fear of 3 C's, right? I'm not going to go through that mnemonic today. You can read that by yourself. So some of the symptoms are palpitation, heart pounding, sweating, and a lot of it is around hands, trembling, sense of shortness of breath, feeling of choking, chest pain, nausea, abdominal discomfort, feeling dizzy, unsteady, lightheaded, or faint, chills or heat sensation, numbness, depersonalization. So all of these are symptoms of panic attacks, which are associated in that 30 minutes of panic attacks happening, and you need almost 4 of them. Now, when these panic attacks happen, there should be one of these. There should be a worry about having more panic attacks, and that can cause significant change in maladaptive behaviors, like avoiding places, which has driven panic attacks in the past, or any other unfamiliar situation. So we see a few things here. So you have recurrence, you have unexpected panic attacks, you have symptoms which are associated with panic attacks, you have time, and then you have an impact of those panic attacks, which can be persistent worries or change in maladaptive behaviors. And this is a DSM-5. What briefly tells you is that panic disorder is a diagnosis of exclusion. So you need to rule out other situations which can cause panic attacks or panic. This can be a substance use situation. This can happen in medical conditions like hyperthyroidism. Pheochromocytoma is one that will frequently show up on your exams, and it is not explained by another mental health illness. So that's why a thorough evaluation is really necessary to reach out to a point. Here is a scale, and Waleed will share this with you, so you can also look at scale and how does you can measure for it. And I know in Pakistan, time is very critical when you're in clinical practice. So if you're seeing a patient, they can fill it out before they see you, so you can track their progress. How are they progressing in the treatment? So that can be really helpful in knowing whether treatment is working. So some of the treatments we'll talk more about that. Treatments are mostly around SSRIs, and SNRIs. SSRIs are selective serotonin reuptake inhibitors, and then serotonin norepinephrine reuptake inhibitors. You can also use benzodiazepines. I think benzodiazepine should be used only in situation when there is significant impairment and people cannot wait for those 3 to 4 weeks for antidepressants to work. And just remember, it is a short-term therapy. Use it for short-term, 4 to 6 weeks, and then try to taper patients off. CBT can be very effective for anxiety disorders, and always consider this if you have that availability in Pakistan. And it's mostly work on behavioral measures and cognitive restructuring. So we'll move on. Next one is agoraphobia. So it is usually fear of public transportation, being in open places, being in closed places, standing in line, or being outside of the home alone. So these situations can cause agoraphobia, and these patients avoid being in those situations, and they can cause significant embarrassing symptoms like fear of incontinence and things like that. Okay, so it should be there for 6 months. You should look at other diagnoses that can also cause some of these conditions. And if it is happening in setting of other medical conditions, it should be significant. And then generalized anxiety disorder. So this is something that along with panic disorders, you will see quite significantly in your patient population. So generalized anxiety disorder is a pattern of frequent worries, you will see these people, they worry a lot, they get overwhelmed easily, get nervous easily. And one word that would describe those feelings is they could catastrophize everything. Even small things, they will make it into big worries. And then that can be really difficult for them to handle. So and it's okay to have some anxiety, like before exams, fear of missing a flight. These are some of the normal worries that we have. What differentiate between both of them is the excessiveness of it and how much impairment does that cause. That's the point. And there is some clinical judgment in that too. So generally, I would ask people, how have people commented on their worries? How does it feel like to them when they compare it to some of the other people? And these patients can have some motor tension, which can reflect in shakiness, restlessness, headache, and it's a chronic pattern that may last for long. So now with panic disorder, with DSM-5, just remember, there are some core symptoms that needs to happen. So like with the panic attacks we discussed here, with the generalized anxiety disorder, there can be excessive worries, nervousness, and being overwhelmed. Okay, and this should be happening for more days than in the last 6 months. So if it happened, once 6 months ago, you really want to think whether it's an anxiety disorder or whether something else is going on there. And these worries are really difficult to control. And people will tell you that my mind is like racing all the time, and I have so much to think about, so much to worry about. And this can reflect in these symptoms. And you need 3 out of 6. Now, DSM-5 is big on numbers, right? 6 months, 3 out of 6. But these are guidelines for us too. So I would still, if it is for 5 months and patient is significantly impaired, I will treat it as like generalized anxiety disorder. The mnemonic for this one is I love mnemonics because that keeps me sane. So mnemonics for generalized anxiety disorder is watchers. So W is for excessive worries. A is for let me see what A would be for. I will think it. So T is for muscle tension, and C is for concentration, difficulty concentrating or mind going back. H is for, again, for headache. E is for energy, so these people can have fatigue. R is for restlessness, and S is for sleep disturbances, difficulty falling asleep or staying asleep. So these people have initial insomnia and middle insomnia. So A was for actually anger or irritability. So just remember muscle tension, which can reflect in neck pain. A is for muscle tension. C is for concentration. H is for hyperarousal. E is for energy. R is for restlessness. S is for sleep. And only one item is required in children. So in children, because illness is still presenting and they can have far more symptoms, only one symptom is required. Again, the one thing that you need to remember in mental health disorder is the level of impairment or level of dysfunctioning that it can cause to the patients. That is critical in diagnosis. And, always think of what else can be causing these situations or medical condition. Hyperthyroidism, again, sometimes, people who are using drugs, it can also cause some significant anxiety or worries. And it should not be explained by another disorder. I use GAD-7, and it is freely available. It's GAD-7. You can Google for that, and you can also download it on your clinic for free use. Now, management of anxiety disorder. So therapy is very critical. And I know in Pakistan, resources are very limited for therapy, but it really helps with the dosage. It also helps with the relapse prevention. One of the therapy options that is available in Pakistan too is cognitive behavioral therapy. So as the name suggests, is the cognitive piece, and then there is a behavioral piece. In behavioral piece, you work on, for example, deep muscle relaxation, progressive muscle relaxation and deep breathing and other techniques to help patient, feel a sense of control. And cognitive piece mostly work on checking those thoughts that are going on behind and what is the underlying thing that is driving that anxiety and restructuring those thoughts. And you may not have time to do this in your clinic, so you may need to refer this patient out. And sometimes there are a lot of YouTube videos too, so you can also ask patients to look out for YouTube videos or muscle relaxation, deep breathing, and some of them are very simple. You can just teach them in clinic too if you have time. And psychodynamic therapy, psychoanalytic therapy, probably not available in Pakistan. Now, for medications, so some of the medications that we frequently use for generalized anxiety too, and I also mentioned in panic disorder, is SSRIs, which are your fluoxetine, citalopram, escitalopram, sertraline, paroxetine, and fluvoxamine. You can also use your SNRIs, which are venlafaxine, duloxetine. We also have Prosteq, which is dysvenlafaxine. I don't know if it is available in Pakistan or not. And then Remeron or metrazapine can also use for anxiety. There are some older medication like TCAs and MIs that are available. And we will go over some other options. So usually we try to start off with cognitive behavioral therapy in one of the SSRIs. One thing that we need to do when we are using psychotropic medications is you need to aim for therapeutic dose. For example, the therapeutic dose for sertraline is 50 to 200 milligram. If you are sitting on 50 milligram for 6 months and if it's not working, or on 25 milligram, and if it's not working in an adult population, it's not working because it's too low of the dose. So you need to increase that dose to a therapeutic dose range. So usually we go, aim for a duration of 8 to 12 months in therapeutic doses. And if it's not working, then look for other options. In medication treatment, if patient has partial response, you can augment antidepressants. You can also add CBT. If no response, then cognitive behavioral therapy or add a different antidepressant. So I'm on step 2. Similarly, with cognitive behavioral therapy, if there's a partial response, you can add more sessions. You can add a first-line antidepressants. Or if there's no response, then you can augment or you do the same thing. And then evaluate the response. And this is why doing those screening measures are more important. And then, in step 3, you can consider second or third line of antidepressants, so which can be SNRIs, venlafaxine, metrazapine, clomipramine, and CBT. Sorry, there's a Zoom navigator, so I cannot see the end of it. But these slide sets would be available to you. For medications, benzodiazepine are not the first line of the treatment. I just want to say it out loud. Use low-dose long-acting benzodiazepine. So alprazolam is quite frequently used in Pakistan. I will recommend using maybe something like clonazepam if you need to use it, and use it for very short term, for 4 to 6 weeks, and then try to taper patient off. Otherwise, they're gonna go into habit of using it more and more, and then you need to increase the dose. Neuroleptic medications are antipsychotics. They are not first-line medications, again, for anxiety disorder. Only there is evidence for quetiapine and olanzapine if you have exhausted many options before using these one. I have not typically used this because I work with adolescents So we don't get to that doses unless dose medication unless there is a reason. Generally, I would start with one medication if I'm going off of medication, which would be SSRIs. If there is significant impairment, and I need to add something, then I will add another medication. But my goal is always to go back to one medication. With anxiety disorders, start with lower doses of medications. Like if you're starting sertraline, start with 25 milligram. And if patient is tolerating it okay, go to 50 milligram, but then increase the dose. Don't sit on those doses for too long. In some of the landmark studies, the average doses were achieved. So for example, sertraline, adolescents average dose is 125 milligram. So in one of the trials, CAM study, in that study they went up to that dose in 8 to 12 weeks, so around 8 weeks. So it's really critical to go for average doses that work for patients. Paroxetine is category D for pregnancy. Others are category C. For children, fluoxetine and then sertraline. But I think that is very individual response. You can start with Lexapro escitalopram. We tend to stay away from paroxetine in adolescents, but if there is a family history of response, you can also use paroxetine. And just remember, fluoxetine can be a little bit activating too in patients. For geriatric population, start with sertraline, citalopram, escitalopram. The reason being that fluoxetine has significant drug-drug interactions. It is safe to use, if they're using it, but the choice would be to go with someone that does not have significant drug-drug interactions. And just remember with citalopram, there was FDA warning that came in, and the max dose went from 60 to 40 milligram. That is QTc prolongation. So if patient has QTc prolongation, you need to be aware of that. Black box warning with suicide. How are we doing at time, Dr. Ahid?
So we can go. You can complete.
Okay. So black box warning with suicide, I think this is really something that we need to talk about more often and educate our patient population. So age 24 and less, there is an increased risk of suicide with antidepressant. It's just not SSRIs, it's all antidepressants. If I quantify those numbers for you, this warning came in 2004 by FDA, and then there were significant studies done after that. There was a meta-analysis that was done in that population where there is an increased risk. In that meta-analysis, I hope all of you know what meta-analysis means. There were 4,500 patients. So 4,500 patients, 4 of them, they had increase in suicidal, 4% had increased suicidal ideations. So 4 out of 100. 2 out of 100 had on placebo, who were on placebo had increase in suicidal ideation. So your absolute risk is about only 2%. And there were no completed suicide. So yes, antidepressants can cause increase in suicidal ideations, but the risk is only 2%. There were some other studies that were done because after this warning, there was a decline in SSRI prescription for antidepressant, as an antidepressant for depression patients. And I saw some studies where there was a decline up to 30% in SSRI prescription. And in those studies, the frequency of suicidal ideation went up to 20 to 25%. And the completed suicide numbers, there were completed suicides too. So here's your comparison. So if you treat with medication, your risk is almost about 4% with medication and 2% with placebo. If you don't treat, that risk goes up to 20 to 25%. So the risk is far larger with medications, without medications. So you need to educate your patients. You need to see them more often, and you need to talk about what if it happens, what do we need to do next? You stop medications, you assess the severity of suicide. That can be a whole different topic. So I'm just going to leave it there. And if there's something that comes in question, we can talk about that. With SSRIs, obviously, you need to look for any hypersensitivities. If they are using MAOIs or TCAs, you need to watch for that. With MAOIs, there is increased risk of serotonin syndrome. Sometimes, if patients are taking, medications, other medications that can increase serotonin, that can also cause serotonin syndrome. SSRIs are usually prescribed once a day. For some reason, I've been seeing these prescriptions from Pakistan, and it's usually prescribed twice a day. There's no reason to prescribe fluoxetine, citalopram, escitalopram, and paroxetine twice a day. Once a day medication, unless you see, I have not seen any patients in my patient population that would need twice a day. Most need once a day, it should be okay. And, if patient has significant sedation, you can dose at night. But, I don't think there is a reason to dose it twice a day. Fluvoxamine is one medication that you can dose twice a day if the dose range exceeds more than 100 milligram. Some of the side effects that can happen, and I want to go over some of them. Most side effects happen with antidepressants pretty early on in the treatment. So first 1 to 3 days. So you need to educate your patients that it will go away if they keep taking their medications. So they are aware of the edge. And once, if it still lasts, if it's causing significant impairment, then, you need to see what can you do. So sexual dysfunction is very common with SSRIs. And it should not be, it's not something that stops us from prescribing antidepressants, but you need to ask your patients about sexual dysfunction. If you don't ask, they're not going to tell you. Then drowsiness and sleepiness can happen. It generally goes away if you dose at night. That does help. Weight gain can happen somewhat with some antidepressant, not a major concern. Then headaches, dry mouth can happen, especially with medications that have anticholinergic effect, one of them being citalopram. Constipation, stomach upset, all of these things can happen. They can also cause movement disorder in a very small number of patients. And then there is a recent growing evidence for GI bleeding with SSRIs. And one of the places where serotonin exists is it is in the platelets. So it caused that platelet dysfunction because of its mechanism of action that can cause GI bleeding. It should not be a reason not to start a medication, but if patient has going for a surgery, you need to look for that, or major surgeries. If patient have history of significant bleeding, you need to watch for that, what is causing what. Diarrhea with sertraline can happen. And then next is activation symptoms. These happen mostly with children and adolescent population, and especially patients who may have neurodevelopmental disorder, with intellectual disability, most likely to happen with fluoxetine and sertraline. But sometimes, other medication can cause what we can cause an activation syndrome that can look like insomnia, irritability, agitation, aggression, significant anxiety. And mostly it happens if you ramp up medications too fast. So you need to be a little bit cautious in children and adolescents when you increase those doses, and discontinuation help with those patients. We already talked about, citalopram and the risk of QTC prolongation in those patients. Some of the other medications, venlafaxine and duloxetine, can be used for generalized anxiety disorder. With venlafaxine, just watch for blood pressure. Also, with duloxetine, look for any liver abnormalities. One place where duloxetine can be helpful is It is also used in some pain syndromes. So if patient comes to you with anxiety and pain, and then that's where duloxetine can be a useful option. Buspirone, which is 5-HT1C, 1A or 1C agonist, I think it's 1A agonist. It can be used as an adjunct medication. Most patients will see improvement at higher doses. It is, in my opinion, it is a, side effects wise, it's well tolerated, but you need to go to higher doses to see the benefit. TCA is clomipramine, which is indicated for OCD and panic disorder. Mipramine has indications for panic disorders and treatment-resistant GAD. Doxepin can be used for anxiety and insomnia. In very low doses, it does help with insomnia. Mirtazapine can be used for panic disorder and many other anxiety disorders. It is good for sleep too, but it can cause weight gain. So you need to talk to patients about weight gain. And it is a sedating medication, so it's prescribed at night. Trazodone has some evidence. I don't use it quite frequently, and working with adolescents, we tend to start with other medications. Hydroxyzine can be used as needed for anxiety. So in patients who have substance use disorders, you can also use hydroxyzine for as needed anxiety. It's an antihistamine H1 blocker. 20 to 50 milligram can be used as needed for anxiety. Because of its mechanism of action, it can cause confusion in elderly population, so try to avoid. And then MAOIs inhibitor, we talk about that. I don't know how many of you use that.